My name is John Deanfield and I'm Professor of Cardiology at University College and Head of the Cardiovascular Prevention Centre. I also am Director of NICOR, the National Institute of Cardiovascular Outcomes Research. Now, NICOR is a very important organisation which collects all the major outcome data for the treatments of heart disease in the country and its major complications. For example, we have the records of all the heart attacks, heart surgery, heart failure, rhythm disturbances, and other major cardiovascular complications. And these allow us to understand what's happening in terms of trends of heart disease in the population and what we can do by collecting the outcome data to try to feed back to improve the care of patients in the country who have heart disease. So the collection of rigorous and complete outcome data is an extremely important part of the management of heart disease risk in the population. Now, much of the benefit that's been obtained in reducing the risk of heart disease in the population has been around better treatment of people who have the complications of heart disease. For example, when patients come to us with a heart attack or even a stroke, we now have methods to reduce the damage in their heart and in their brain by better management of the acute complications. And this has been tremendously successful in reducing mortality from heart disease in the country. In fact, heart disease mortality has reduced by almost 50% in the last 20 or so years as a result of a collaboration between politicians, healthcare providers, doctors, and indeed the public to really focus on reducing this most important killer in our society. However, if we're going to do better in the future, we have to focus not only on better treatment of patients who've got this disease, but really try to deal with the prevention of heart disease in the population. And many people have risk factors that we know are likely to increase their risk of having a future cardiovascular event like a stroke or a heart attack. Now, we know many of those cardiovascular risk factors that contribute to future risk. They include smoking, high cholesterol, high blood pressure, diabetes, a bad family history, being overweight, having sedentary behavior, and various dietary factors. And we have a tremendous opportunity to understand how modifying those risk factors from early life can actually improve the chances of having a heart attack or stroke in the future. And the concentration of prevention is going to be a very important component of our efforts to reduce further the burden of heart disease in the population. Now, the Joint British Societies 3, or JBS3 guidelines, which are being reported this week, represent the consensus of the medical community in how we would best approach reducing cardiovascular risk in the population. They target not only the new information that we have about better treatment of patients with heart disease, but focus much more perhaps than previous guidelines on this idea of investing in your arteries by reducing risk factors over your lifetime. We realize that there are many similarities between financial saving and healthcare management. If you were saving for your retirement for the future, you wouldn't start when you were 64 years of age, but you would start much earlier. And we believe that heart disease management will have to be considered in a similar way. So understanding how risk factors are operating from early life to drive future heart disease and how we can reduce the future burden of disease by tackling that early life stage of risk factors is becoming increasingly important and is a major focus of the JBS3 calculations. Now, in JBS3, we've introduced a new calculator which we think is much easier to understand than previous efforts to inform the public about their risk of heart disease. Instead of just quoting a 10-year risk of having a heart attack or a stroke, which is the traditional way, we're actually giving the public the opportunity to understand the potential benefits from early treatment over years before they get into a high-risk situation. We're going to be able to tell individuals about their heart age, for example, how old their heart is in relationship to their real chronological age. We're also going to be able to give us a metric of the future, how long people can expect to live healthily before they get into trouble with their heart based on their current risk factor profile. And we think this type of information is very easy to understand and something that will allow people to take control, if you like, of their own cardiovascular risk for the future. Now, the calculator does one more very important thing. It allows individuals to take their risk factor profile and then alter it in the way that might be easily achieved either by diet, by lifestyle change, or by medication, and seeing what impact that has on their future cardiovascular risk. And this combination of understanding about their heart disease risk and the opportunity to see the benefits that they might achieve by early management of their cardiovascular risk profile, we hope will be a powerful new addition to persuade the public that heart disease management is really important for their future well-being. Now, the JBS3 calculator and our approach to risk factor management over lifetime has an important link to what we're trying to achieve in NICOR. What we would like to be able to do is to evaluate the impact of this new approach to cardiovascular risk communication and management on the health of the population. Now, in NICOR, we record the major cardiovascular complications, and it will be possible in the future, we believe, to test the impact of JBS3 in the population on its ability to inform, educate, change behavior, and hopefully reduce the future burden of heart disease as we measure it in NICOR. We can link, for example, to the health checks program that Public Health England fund in the UK to measure cardiovascular risk in the population. Try to link the measurement of risk factors to the new appraisal of cardiovascular risk, and then see whether the behavior change we hope will be introduced by this new measurement translates to reduced heart attacks, strokes, and other cardiovascular complications.